And then is the leptin receptor, it's not 8%, it's 3% of the cases of fat. Without any other features, you will think of leptin receptor deficiency. And then melanocortin 4 receptor deficiency. And if you find a child with obese, hypogonadism, slight developmental delay, and the hair color is not conforming to the family, then you need to think of your pro-opiomelanocortin deficiency. So these are the monogenic obesity that I was talking of. And then this is an FTA gene. Sometimes we blame the person, sometimes we blame the children that they are not being able to control their hunger or their greediness for the food. But it is the FTO gene which is there, they will go on taking. Like we blame the alcoholics, but again, that's a gene they are having that they cannot control. And then comes the ghrelin. The role of ghrelin in obesity is important because it is produced in the stomach, and this and the pancreas and hypothalamus, and this is the ghrelin is the one which forces us to take. So one of the idea of having the bariatric surgery is that to take out a portion of this ghrelin producing area and the stomach from the stomach, and that's what the ghrelin does. And Prader-Willi syndrome is another disorder where the plasma ghrelin will be high, so they go on taking foods. I'm not going to touch, but everywhere there is probiotic, and Dr. Sarath Gopalan, whom I admire because of his knowledge, because of his delivery, and he has already talked to you about obesity. Endocrine obesity is the one where most of the time the obese children are misdiagnosed. Endocrine obesity is much less common, but every obese child will get a thyroxine. But it's not that common actually, but there is a trap for that, because the central obesity that you see in Cushing syndrome, you will not get in pediatric Cushing syndrome. It's a generalized obesity. So that needs to be taken care of, that the Cushing syndrome you will miss because you expect a generalized obesity. And you know about hypothyroidism, growth hormone deficiency, pseudo-hypoparathyroidism, where your third and fourth metacarpals will be short. And then is the Rohan-Date syndrome, which has come up recently, is that it's a hypothalamic disorder. Extreme obesity, rapid onset early obesity is the Rohan-Date obesity. So how do you evaluate for them? Thyroid axis T3 levels will be raised, and TSH may be just above or upper limit of normal. And that's where the problem is, that because of the obesity, they have a little bit of TSH raised and they get the thyroxine, but without any benefit. Then the adrenal axis, you know that the pseudocasting, like we have done the dexamethasone low dose, high dose to differentiate between obesity, Cushing syndrome, and depressions in our school days, medical school days. And then the growth hormone levels will be low, but the growth hormone level, even if it is low, but if you do the IGF-1 and IGF-BP3, it will be normal. So that's what in endocrine you do. Again, the sleep and obesity is, again, people say that if you decrease sleep, then it's a chance of obesity. There are a lot of theories behind, but what I suggest to all my junior colleagues, that sleep well. At least 8 to 9 hours of sleep is necessary, because the recent concept is that whatever you learn during the day, it goes into your hard disk, into your memory during the night. And if you don't do that, you have a very short memory, and then you forget everything. So sleep is very important. And why? See, because of the less sleep is the low leptin, high ghrelin, and other hormones, sufficient time to eat. So if you are studying, you go and open the fridge and again you take some foods. And that's the usual one, the sleep causes obesity. Now, what we miss? We do a lot of MRIs, but how many of you do the polysomnography? Polysomnography is a very important test. The polysomnography cost in Calcutta 9,000 rupees, MRI cost 10,000, 11,000 rupees. And with polysomnography, you will be able to see that how the oxygen saturation is falling, how the obstruction in the chest is happening, with how his EEG changes are there. And it's a very good indicator that if you have got changes in the polysomnography, then it's an indication that you will have to do most probably the tonsils and adenoid to be taken off, and you will have to decrease the obesity in whatever the way it is, because it will have a long-term effect on your brain. And obesity is again a body image. The studies has shown really very peculiar ones. See, many of the obese people, they think they are not obese. It's just the opposite of anorexia nervosa. And this has been studied that the 9 types of figures were given to 2,56 females. And many of them who are obese wanted that figure only, or maybe slightly fatter than that. So that means what? That means that they have a disturbed body image. So you will not be able to convince them that they are fat. So that is also where you need little bit of psychotherapy, that the obesity is a disturbed body image. And then obesity, is it related to infections? And one of the recent concept is that obesity is because of an infection by adenovirus 36. And this study was done by an Indian, and his name is Mr. Dhurandhar. So I don't know whether it is true or false, but the name who did it is Mr. Dhurandhar. And adenovirus 36, this obesity, it works, these viruses, they work at different levels. The canine virus towards the center, on the adipose tissue is the adenovirus, and then lot of Bornavirus, hypothalamus, crappy agents, they can also be infections. And then obesity is an epigenetics. I have already told you about the thrifty genes, that just like asthma, obesity these 3 mouse are carrying the same gene, but they are of different size and shape and color, and that's what the epigenetics is. And last but not the least, I don't think it's not the last, is the fetal programming, that you are destined to be fat, and that's what the Barker hypothesis is. And if you are destined to be fat, you will be fat no matter whatever you do. The problem is, suppose you are destined to be thinner because you are small for death, and the parents want you to be fatter, then is the problem. It's something like that I had a Maruti 800 car, and after I purchased the new car, I wanted to use this car as a school van. I have increased the size, and I want to have more persons included in it, and so it will break down very fast. So if you are destined to be thin, be thin, let them remain thin, don't try to make them fat, because the fetal programming will be changed, and they are the ones who will have the metabolic syndromes, as you can see. So coming to the clinical part, I have already talked to you about the exogenous and endogenous obesity, and then we have a concept that the males have this android or the apple type of obesity, the females has got the pear-shaped obesity. If you accumulate fat in your pelvis, it's not going to go away. It's not going to go away. You can take off the central obesity fats, but not the pear-shaped fats. And people say that if you have an apple-shaped obesity, you are more prone to have diabetes and hypertension and insulin resistance. But this theory is gradually being disproved that no, it's not true. And when you examine them thoroughly. What are the things that you should look for? You must check the blood pressure, you must check the airway obstruction, you check the axilla for the acanthosis nigricans, you look at the genitalia because a lot of them may be associated with genital problems, you look for the stria, you look for the tibia because of the bowing. And then I have already told you that how to diagnose this. These are the 2 children with Bardet-Biedl syndrome. Both of them is now having retinitis pigmentosa and night vision problems. And this is what a pseudo hypoparathyroidism. So you look at the fingers that whether the third and fourth metacarpals are short or not. And this is the penis of the same child. The one, it looks like this is a buried penis. So when you look at the penis and see that this child will be all right if you can take off the fat.